Okay, welcome back everybody, and we're now fully back on air, live streamed. Again, we are now in a session which is dedicated to the whole area of treatment. If I can get your attention please, folks, we're back on. Can I ask people at the back to please take the chairs? Okay, we're now in the whole session which is dedicated to treatment. And again, as always, I'll introduce the panellists individually as they come forward. And firstly, I'd like to welcome Dr. Anne-Marie Carew. We had a Health Research Board presentation this morning, and this report issued just mid-week of this week, and I think it was a very good, very clear report setting out the very changing nature of drug use in Ireland. So I'm pleased that Dr. Anne-Marie Carew is here today to share with us in a bit of detail. Thank you, Anne-Marie.
Thanks, Paul. Good afternoon, everyone. Thank you all for the opportunity to be here with you today. I'm going to present data which is collected by the Health Research Board on drug treatment demand. Now, treatment demand is an important measure. It tells us about the numbers and the profiles of those that are entering treatment every year. It's useful for service planning and for generating evidence for policy. Treatment demand can be used as a proxy measure for what's happening in the general population and tell us about drug use in the general population. The data I'm going to present here really matters because behind every number that you're going to see or every fact that I'm going to present are real people whose lives have been impacted by drug use, and they've come forward and they have sought treatment. So first of all, I'm just going to tell you a little bit about the system. The National Drug Treatment Reporting System collects the data on treatment demand. Under the current National Drug Strategy, there's a requirement that all publicly funded services, drug and alcohol services across the country, report data to the NDTRS for all people that use their services. Our coverage is high. Around 90% of day and residential services report data to the system. We collect data on cases, both those that have never been in treatment before and those that are returning. Trusted service providers across the country obtain consent from individuals, and they collect the data and return it to ourselves. And the type of data, you'll see some examples here on the slide. It includes age, gender, and the types of treatments that are being provided. So last year, approximately 350 services from right across the country provided us with data on treatment. Outpatient services are day services. For example, you might attend a counselling service or counselling session at a day service. Inpatient services, or we also call them residential services, is where you stay overnight. So an example of that would be an inpatient detoxification facility, for example. Low threshold services, which you'll see here, these are services that are typically low dose methadone or community-based drop-in services. Once referred to a service, the data tells us that generally treatment takes place in a timely fashion. Of course, there are variations depending on the type of service that's being accessed. So for example, if you wanted to access a residential service, you may need to wait for a bed to become available. We have here some key trends over the last 7 years, and we have seen an increase in the number of cases entering treatment. The fact that more people are coming forward and they're seeking treatment, this is really encouraging. We've also seen some other positive trends. For example, we've seen a decrease in the number of cases that are reporting injecting. Last year, we had just over 12,000 cases enter treatment, and almost 4 in every 10 cases had never been in treatment before. Here we have the top 4 main problem drugs that we saw last year. You can see here cocaine was the most common, followed closely by opioids, which include heroin, and in fact it's mostly heroin, then cannabis, and then benzodiazepines. Benzodiazepines are, you may have heard earlier, they're prescription drugs, and you may know the name Valium, for example. We're going to look at each of these drugs in a little bit more detail later on in the presentation. Other trends that we saw relate to polydrug use. So we're seeing in our data that nearly 6 in 10 had problem use of more than just one drug. And last year, we see that the most common combinations in the data is for cocaine plus alcohol. In terms of injecting, we see that 1 in 5 cases had injected, and these may have experienced some of the worst harms as a result of drug use. But we have seen a downward trend in injecting and behaviours, and this is really positive. Now, the type of drug for which treatment was sought varies by age. You can see here on the slide that among younger people, it's predominantly cannabis. For those that are in their 20s to mid-30s, it's cocaine. And among the older age groups, it's predominantly opioids or heroin. I'm going to take you through the four main types of drugs that we saw last year. So I'm going to start with cocaine, and we'll start to look at the profiles of who are entering treatments for these substances. So there are different types of cocaine. As you know, the most common that we see in Ireland is powder cocaine, and it accounted for 8 in every 10 cases entering treatment for problem cocaine use last year. The other main one that we see is crack cocaine, and the numbers for crack cocaine have increased. It's less common, but it is the other type that we see. In terms of powder cocaine, what we have here is the typical profile, and it tends to be young males who are working. About half had never been in treatment before, and it was common to have problem use of several drugs. In addition to cocaine, many were also treated for problem alcohol or cannabis use. Then looking to crack cocaine, as you know, crack cocaine is more addictive and it can be more harmful. As I said earlier, the numbers are increasing, and last year crack accounted for 1 in every 5 cocaine treatments that we saw. The profile here is very different. These cases are more likely to be unemployed, more likely to be homeless, and most have been in treatment previously. Many were also female. In addition to crack, it was common to see problem use of opioids, benzodiazepines, and cannabis use. And we also see that 1 in 3 had injected, and many were still injecting at the time that they sought treatment. Moving on then to opioids. This was predominantly heroin, as I said earlier. The profile is typically older males. Most have been in drug treatment before. The majority were unemployed. In addition to opioids, there was often problematic use of cocaine, benzodiazepines, and cannabis. And we also see for this group that injecting was common. Next is cannabis. Now, this profile is different to the others that we've seen. It is typically young males who have never been in drug treatment before. And you'll see here on the slide, many are students. Polydrug use was less common among this group, but where there was problematic use of other drugs, it was most likely to be cocaine and alcohol. Benzodiazepines did appear as well alongside cannabis. Finally, we're coming to the last profile that I'm going to talk about, and it's benzodiazepines. The profile is typically older males that have been in treatment before. Similar to the other groups, we see polydrug use is common, and in addition to benzos, there was also problematic use of cannabis, opioids, and alcohol as well. What we have here is the first drug ever used and the age starting to use drugs. So for all the groups that we've looked at, most started drug use by the time they had reached their early teens. And you can see here on the slide, most started drug use by using cannabis. What's not here on the slide is alcohol, and where alcohol was a problem, half of cases had started to use alcohol by the time they were 14 years of age. Next, I'm going to show you some data about special or vulnerable groups. The first is parents and children, and you've heard quite a bit about parents and children already today. The impact of drug use can be wide-reaching. Children are particularly vulnerable to the drug-related harms, and also we know that there can be barriers to treatment for parents that want to access treatment. So the fear of losing their children, stigma, the practicalities of who's going to mind the kids while the parent attends for treatment. Last year, we see in our data that almost half of cases entering treatment for problem drug use had children. 4 in 10 had at least one child living at home with them at the point in time when they accessed treatment. Females were more likely than males to be living with children at the time that they entered treatment. The second group I want to talk about is travellers. We collect data on ethnicity in our system. We know that many don't disclose their ethnicity due to the fear of stigma. However, in the last year we saw nearly 400 cases self-identified as being a member of the Irish traveller community, and they commenced drug treatment. Now, these figures have been included in all of the slides that have gone previously, and the data shows us that the there is a greater need for drug treatment among this group compared to the wider population. If we look at female travellers, we see that opioids and benzodiazepines were the most common drugs for which they were presenting for.
Just 1 minute.
This is different to females in the wider population where it was opioids and cocaine. For men, we see that the profile is similar. In terms of the drugs, it is cocaine plus opioids. But a difference is that male and female travellers were slightly older when they entered treatment than their male and female counterparts in the wider population. I'm going to finish up here with some key messages. I'm conscious that there is quite a lot of information, statistics to take in, so I'm happy to take any questions you might have afterwards. Thank you.
Thank you, Anne-Marie.